Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today we have a special guest, Dr. Ryan Maves, an intensive care and infectious disease doc out on the West Coast, giving us an update on sepsis management in the austere environment. I'd also like to get your thoughts on a little bit of change of format for the PFC podcast. What I'm thinking of doing is having shorter podcasts, but start pumping them out more frequently. But I'm really interested in what you guys think. If you go to the website, make sure to drop your comments. And while you're there, go ahead and subscribe so you don't miss any of the PFC goodness. Now on to the podcast, PFC Sepsis Update with Dr. Ryan Maves.
Hi, I'm Captain Ryan Maves. I'm the Program Director for the Infectious Diseases Fellowship and one of the staff critical care physicians at Naval Medical Center San Diego. I've been asked to talk about infectious diseases in the operational environment. So in all fairness, this is a pretty big topic, and really we're going to focus on our two big categories of things that affect deployed service members, especially in the prolonged field care environment. And those are sepsis and then tropical medicine. Now, in all fairness, it's hard to do justice to two topics of that size in the time allotted, but I think we can at least go over the core basic principles of these problems to shed some light on how to approach the potentially infected patient in the deployed setting, especially in the resource-constrained developing world where you're a long way from any diagnostic testing, you're a long way from advanced therapeutics, but what you do have are your eyes, your ears, your hands, and some basic tools to help you support the critically ill infected patient a long ways away from home and from help. So, sepsis is a term I think we're all pretty familiar with. The definition of sepsis is a challenging one. We lump a lot of different diseases together under this rubric of sepsis, but calling sepsis from penetrating abdominal trauma, or sepsis resulting from a severe pneumonia, or sepsis from a urinary tract infection, calling those all one disease, sepsis, is kind of like calling all cancer just cancer, even though melanoma and lung cancer and breast cancer are obviously very different diseases. But there is a commonality in how we approach them, and there is a commonality in how we manage these problems. So sepsis is fundamentally the combination of infection plus a dysregulated immune response leading to organ failure. That can be respiratory failure, renal failure, shock and cardiovascular collapse. You name it, any of those together, organ failure plus infection equals sepsis. So our definitions of sepsis have changed in the last couple of years, and if you're reading articles about sepsis, you'll notice that some of the older terms have changed. There used to be this thing called SIRS, or Systemic Inflammatory Response Syndrome, and what that was a combination of a high or low white blood cell count, fever or hypothermia, a rapid heart rate of 90 beats per minute or greater, and a rapid respiratory rate, meaning 20 breaths per minute or more. And if you had two or more of these things, you were thought to have, quote, SIRS, unquote. Now, the problem with SIRS is that there are lots of things that can mimic infection in the setting of SIRS, like polytrauma, or a bad burn, or severe pancreatitis, or some drug reactions. So if you had SIRS in combination with infection, that was then called sepsis. Then if you had sepsis in combination with organ dysfunction, that was called severe sepsis. And then if you had severe sepsis with hypotension, if you had a systolic blood pressure of less than 90 after getting some reasonable amount of fluid resuscitation, 2 to 3 liters of crystalloid, then you're considered as having septic shock. So these definitions got changed in part because the old term sepsis wasn't really linked to an increased risk of mortality. And really the idea with sepsis is that it's an infection that could kill you. And so the terminology all got redefined in 2016. The old sepsis, that is SIRS criteria plus infection, now we just call infection, right? If you have infection plus organ failure, this then is considered diagnostic of sepsis because those people have an increased risk of mortality. And then lastly, septic shock pretty much means the same thing, that you have an infection with a low blood pressure despite adequate fluid resuscitation. And so we screen for sepsis using a variety of tools, but one of them is this thing called the Q-SOFA, which is a simple score that looks at three things: a systolic blood pressure of less than 100, a respiratory rate greater than 22 breaths per minute, or the presence of delirium. And if you have two of the three, that's thought to be a positive Q-SOFA and is then suggestive of but not diagnostic of sepsis. So you can find some published recognition algorithms. Some of these are not practical in the deployed field care environment, but a Q-SOFA is pretty easy to do, right? Unlike SIRS, it requires you able to draw labs and check a white count. The Q-SOFA criteria are things you can do at the bedside. The presence of change of mental status, checking a blood pressure, measuring respiratory rate, that at least gets you thinking. So once you've made at least a presumptive diagnosis of sepsis, you have someone who perhaps is febrile, has some other marker of infection, they've met various criteria like the presence of delirium, like a rapid respiratory rate, that makes you think this person is potentially septic. We have to then start thinking about how are we going to intervene. So there are a few kind of unifying principles of sepsis care, right? Even though, again, sepsis due to pneumonia, sepsis due to a urinary tract infection, sepsis due to penetrating abdominal trauma, these are fundamentally different diseases, but there are some things that hold them all together. All right, so these fundamental principles. Number one is sooner is better than later. Sepsis is a medical emergency. It has a higher mortality rate than polytrauma. It has a higher mortality rate than having a myocardial infarction. Early intervention is going to save lives. If you can get cultures, great. Understanding, obviously, in a prolonged field care environment, you may not be able to do that. But it is critical to administer antibiotics, administer fluids, and, if needed and available, vasopressor support as early as possible to maintain organ function and reduce the risk of mortality. All right, the other unifying principle I would say is that something is better than nothing. Now, there are going to be times in sepsis where there are cases where one intervention may be preferable to another. Is it better to give norepinephrine or dopamine or potentially epinephrine as your first-line vasopressor? If we're going to feed someone who's septic, do we give them full nutrition or do we give them partial nutrition? When you're trying to give them fluids, do we give them normal saline or do we give them a balanced crystalloid like lactated ringers? Or do we give them albumin or do we give them plasma or blood? Your options are often highly constrained, right? The fluid you have is the fluid you have. The pressor, in a deployed setting, you may have some epinephrine with you, you may not. But the best vasopressor is the one you have. The best fluid is the one you have. So talking a little bit about the causes of sepsis and the interactions of sepsis, it's helpful to think that the human immune system maintains a careful balance between killing you and letting you die, right? It's people with profoundly impaired immune systems, advanced leukemia, end-stage HIV infection. Those are people who can't defend against external infections. But similarly, if you think about it, our immune system kind of evolved to, help us fight off infection from getting bitten in the leg by a saber-toothed tiger, right? It didn't develop with the idea that we would have an unobstructed urinary tract or an overwhelming pneumonia or bacteria from our gut leaking into our peritoneum, right? And sometimes a high burden of pathogen can lead to a dysregulated response, which leads to a lot of the organ failure we see in sepsis. So another important point is that septic shock is not purely distributive. We think about categories of shock like cardiogenic shock and distributive shock and hypovolemic shock from fluid losses. Septic shock is often described as one of the classic causes of distributive shock, but it's not purely distributive. It's not just vasodilation. You'll see myocardial depression and a loss of myocardial contractility in sepsis. You'll see vasodilation. You get capillary leakage from leaky capillaries in people with severe sepsis. You can actually have microvascular obstruction from small thrombi forming. And then there is often some concomitant component of hypovolemia. So we want to correct these things as best we can, and fluid resuscitation is one of the first steps we make in management of a septic patient. Some fluids are good, but more fluids are not always better, right? And in a typical adult, if it takes more than 2 to 3 liters to correct someone's perfusion and correct someone's blood pressure, and they're not having active ongoing fluid losses, like from severe diarrhea, or obviously in the case of concomitant trauma from hemorrhage. If 2 to 3 liters doesn't fix a normal adult, 5 to 6 liters is unlikely to fix them either. And when we look at studies of volumes of fluid resuscitation in patients with sepsis, there is a point where mortality starts to increase with increasing amounts of fluid resuscitation. When we look at empiric antibiotics, and this isn't an antibiotic talk, but thinking about what can we modify in the care of a septic patient. So, there aren't a lot of things that we can do when a septic patient first presents to us in terms of modifying the risk factors for mortality, right? You can't change their disease. You can't change the organism that's causing their infection. But one thing you can do is you can affect how quickly you give them an active antibiotic. And by active antibiotic, I mean a drug that treats the infection they actually have. There's a pretty famous study by Anand Kumar. It was published in Critical Care Medicine in 2006. And what it looked at was the duration of hypotension before the initiation of effective antibiotics and risk of death. And what it basically comes down to is in patients with septic shock, the longer they're hypotensive until they receive an antibiotic that treats the infection they actually have, their risk of mortality goes up. And it goes up by about 8% per hour, right? And that is going to be one of the big things that you have control over. You can control when they get that drug, and that's going to have a direct impact on their likelihood of survival. Now, in patients who are normotensive but septic, that is, are maintaining their blood pressure, that mortality benefit is not as pronounced. But we're unlikely to get better data than this study. This was a retrospective study, but I don't think anyone's ever going to be randomized to the delayed antibiotics in septic shock arm in a clinical trial. But sooner is better than later. So if we can get an effective drug into someone faster, that's going to be important. Now, what kind of data do we have to extrapolate this to the prolonged field care environment, right? We don't have a ton. There aren't a lot of critical care studies done by small teams of SOCOM operators in the middle of sub-Saharan Africa, right? But we do actually have some useful models for how to take care of septic patients in resource-constrained settings, and that all comes from sepsis care in low-income countries. When we look at low-income countries, what we see is, relatively limited technology, limited diagnostics, and not a lot of availability in terms of advanced technology and infrastructure. But what you do have in these settings are doctors, nurses, medics, health workers who have eyes, who have ears, who have hands, who can reassess patients at the bedside, make an intervention, and then reassess them to see how is the patient's status changing as their illness develops and as their treatments take place. So there are actually interesting discussions in the critical care literature about how do we put the lessons of the Surviving Sepsis campaign, which has had a big impact on mortality from sepsis in developed countries, and how do we apply those to resource-constrained settings like sub-Saharan Africa. So the WHO has guidelines for sepsis management in resource-limited settings. This is published in a thing called the IMAI District Clinician Manual, and you can actually look at this online. You can Google it. But what it is an integrated management of adolescent and adult illnesses guidebook for what are called district clinicians. These may be physicians, these may be trained health workers working in often very remote areas. This was developed through a WHO sepsis working group. And what it comes up with is a flow chart that starts with looking proactively for signs of sepsis in their patients. And then they go through a stepwise pattern of assessing for signs of sepsis, then assessing the patient's circulation, looking at things like tissue perfusion, capillary refill, blood pressure, pulse. In the process of this assessment, they make interventions. If circulation appears abnormal, the tissue is cold, clammy, capillary refill is delayed, blood pressure is low, pulse is weak, thready, and rapid, they start by intervening with crystalloids. If perfusion is inadequate even after crystalloid resuscitation, adding a small amount of epinephrine or dopamine if that's what they have available. to try to correct these abnormalities. The next step then is moving on to assessing ventilation, keeping the airway clear, applying oxygen if available and necessary, putting the patient in a semi-recumbent position with the head up around 30 degrees, just like we do in a ICU at home. If they're unconscious, putting them in a way that protects their airway, and then using whatever kind of non-invasive ventilation strategies they have available, which may just be bag valve mask ventilation. After that, antimicrobial therapy. If they can clinically justify it, they get microbiological cultures before initiation of antimicrobials. That is often not practical in areas like sub-Saharan Africa. It is also often not available, in fact, I would say almost never available in the prolonged field care deployed setting. Then they administer adequate antibiotics in appropriate doses. Next, try to find a diagnosis. This can be by thorough history and physical, going over every inch of the patient, listening to the heart and lungs, looking at the mouth, looking at the skin, looking at the back, pushing on the belly. Then lastly, if possible, source control. If there is an infected wound, if there is an abscess, debriding it, draining it, doing the best they can to get the infected nidus out of the body. And then reassess at every step, going back and reassessing. So what are some models we have that we can take from the literature to see if they apply to the prolonged field care setting? Well, it is interesting to look back at, really of all things, the Ebola epidemic in West Africa in 2013-2014. And actually, as I record this, there is an ongoing Ebola epidemic in the Democratic Republic of Congo, which has been going on since 2018. So in Ebola, what the kinds of interventions that people made that made a difference were replacing lost circulating volume, correcting electrolyte abnormalities as best they could, treating secondary infections when they were present, malaria, bacterial superinfections, but doing this in an often extremely resource-constrained setting. You know, before that Ebola epidemic, people predicted that the mortality of Ebola was 95%. But in Ebola care units in West Africa during the 2013-2014 epidemic, in some centers that mortality was driven down to 40 or 50%, or sometimes even lower, with simple bedside point-of-care interventions. And none of that more important than the clinician caregiver at the bedside. So I've talked a bit about antibiotics, and again, the discussion of kind of the full spectrum of what antibiotic do you give people is a little bit beyond the scope of this discussion. What is interesting is that how special operations units will deploy with a handful of very broad spectrum antibiotics. After most traumatic infections, that is infections resulting from combat trauma, the principal treatment is surgical debridement and washout. That is obviously not possible if you are hours to days away from medevac, although good wound care is a critical part of managing an infected wound. Really, SOCOM units are almost the only people in the world who would use a drug like ertapenem empirically. But it does have a lot of advantages. It's a very broad spectrum, covers a wide variety of what we call gram-positive, gram-negative, and anaerobic infections, and it has a very long half-life, meaning that generally once daily dosing is sufficient. And so what we recommend is ertapenem 1 gram intravenously to be given for contaminated wounds in remote settings where there may be a prolonged delay in definitive care. An alternative agent is moxifloxacin, which is a little less effective but has at least comparable spectrum of activity, and that can be given either intravenously or orally. Ertapenem is only IV. Now, for most wounds, simply prophylactic antibiotics are sufficient, so the uninfected penetrating trauma type of case. In most cases, cefazolin 2 grams IV given every 8 hours for up to a total of 3 doses for the prevention of infection after a combat trauma injury is our recommendation. We'll often recommend the addition of metronidazole, which can be given IV or orally if the GI tract is injured, usually penetrating abdominal injury, or for penetrating head injury as well. There are good guidelines that were published in 2011 on the prevention of infections associated with combat-associated injuries. And I would just point out for the great majority of those in adults, the prophylactic agent is 2 grams of cefazolin. If you don't have cefazolin, obviously ertapenem is sufficient, but it is a lot broader spectrum, and I would try to reserve that for patients with established infections. So, as kind of a proposed summary for the management of sepsis in a prolonged field care environment, what I propose is the following. One is rapid identification. That's looking for signs of tachycardia, tachypnea, and delirium. Next is going to be resuscitation. 2 to 3 liters of crystalloid is reasonable in the absence of ongoing fluid losses. If that's insufficient to restore normal circulation, the addition of vasopressors is useful. Epinephrine is often in PFC kits carried by SOCOM medics, and these can be converted into a epinephrine drip that will help support blood pressure and support peripheral perfusion. I should mention a recent study called the Andromeda Shock study that was done in South American intensive care units, but it compared laboratory testing-based assessments of resuscitation, that is using testing of blood lactate, to simply at the bedside assessing capillary refill. They would push down on the patient's thumb for 10 seconds, then let go, and then count how many seconds it took for capillary refill to be restored. If it was greater than 3, they continued their resuscitative efforts. That hasn't been studied yet in a deployed setting, but it's very provocative, and I think it gives us another tool to see how well have we resuscitated this patient. Next step is going to be source control. The practicality of that is going to be limited, especially in cases of penetrating head, thoracic, or abdominal trauma, but certainly something on the extremities could be washed out, potentially debrided. Then lastly, early antibiotics, and I emphasize that you guys are the only people in the world who use empiric ertapenem.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.